Well, I have a short period of time to try to convince you that you don't have to go around the world to have an awesome experience. You can have that right here on this campus. And how many of you are they all STEM undergrads, or are they public health? Shout out some majors in here. Kinesiology. Studio arts. Very, very good. So, as you can see, the Affordable Care Act. This week we had an awesome event on our campus. It was called Public Health Research in Maryland. Raise your hand if you attended any of the events. Just a handful. Okay, let's understand. 300 plus people from across the state, including our colleagues from the University of Maryland, Baltimore, descended on this campus. And I think what was most impressive was the U.S. Public Health Service Commission Corps. Raise your hand if you've ever heard of the Commission Corps. That's not everybody. The Commission Corps is a part of the U.S. Government, part of the military, and it has a fascinating history. It is the Commission Corps that is a part of the Centers for Disease Control, and when there's an outbreak, you've been reading about the outbreaks of Ebola, they'll send in the Epidemic Intelligence Service, drop you into a remote place and try to stop the spread of infectious diseases. Those are public health service officers. So you need to think about that when you think about career options. Going into the Commission Corps can also provide resources for you to complete your education and your training. So, again, exposure to public health gives them exposure to the Commission Corps and another way of practicing medicine. Well, they were all on this campus yesterday, and it included 2 former Surgeon Generals of the United States, Surgeon General David Satcher and Surgeon General Carmona. I had the pleasure of working with Dr. Satcher when he was director of the Centers for Disease Control and Prevention. And I'll talk a little bit about some of the work that we did together. Should I be using this mic for the...
Would you ask, who might be better?
Yeah, you're recording. Let's see if this works. How long do I have? You've given me a mic and an audience. Thank you.
The tape is 90 minutes long.
Oh, okay. Don't go more than 90 minutes. Is there a remote clicker? Okay. Not all. Stand behind the desk. Okay. I'm good. So take a look here at this image. I always wonder, should I ask? You know what that is? All right. Thank you. So, what you may not know is that this image was created by one of your undergrad students here at the University of Maryland. Because 2 years ago, we celebrated the 150-year anniversary of the Emancipation Proclamation and the 50-year anniversary of the March on Washington. And partnering with the Clarice Smith Center for the Performing Arts, I got some artists in here, we had a campaign called Civil War to Civil Rights, the Well-Being of the Nation. And are we also connected to the internet?
Yes, I have that up when you came in, so if you minimize this, you can
So we get a chance, I'll show you something that we produced with the Clarice Smith Center. And what I might do if I run this little piece, we might pause the tape so we don't run out. Do I have to do anything special?
I don't know, I had Explorer open.
You did?
Yeah.
Here's what I'm going to do. I don't want the technology to get in the way of what we're talking about. So let me just stop. We'll see if we can come back to it before we finish. So what I'm trying to do is set the stage for you to understand why it is that in the 21st century we have people dying from diseases that are totally preventable. And why we have people benefiting from all the scientific advancements in medicine and public health, but everyone is not benefiting equally. Why is that in the 21st century? So I'm going to share with you some of my talk yesterday at the meeting. And you can see it focused on the Affordable Care Act, implementation, intended and unintended consequences. And that my focus was on eliminating racial and ethnic health disparities, and I'm calling for less talk and more action, okay? So, here we go. Now I share this with you because I arrived on this campus in 2010 from the University of Pittsburgh. And the School of Public Health was established in 2007, was accredited in 2010. And the founding dean at the time said, in order for us to be a world-class School of Public Health, we need a research enterprise focused on health equity and health disparities. And they thought about how they were going to do that. They could grow their own over the next decade, or like they do in the private sector, they could acquire it. And to make a long story short, they came after yours truly. And when I told my crew that the University of Maryland was trying to recruit us, they said, don't leave me. So that dean was looking at not just one person, but five. Not easy. The fact that I'm here standing in front of you is a testament, not so much to me, but a testament to the institutional commitment here at the University of Maryland. We're the largest cluster hire in the history of the university. We were recruited here to launch the Maryland Center for Health Equity. So from left to right, this is Dr. Mary Garza, assistant professor in the Department of Behavioral and Community Health and School of Public Health, and an associate director in the Center for Health Equity. Dr. Craig Fryer, same title. Yours truly, Dr. Sandra Quinn, is the senior associate director in the Center for Health Equity, professor in family science, and the associate dean for academic affairs in the School of Public Health, and Dr. James Butler. You see our sign there, which was created by the University of Maryland. Health equity is our future. Now we have a few years under our belt. I'm happy to share with you some of the things that we've accomplished, and I'm just so excited to finally meet this connection. I have not had this connection. Let me direct your attention to our December issue of the American Journal of Public Health, where Dr. Quinn and I served with Nancy Cass to edit a theme issue of the journal. This is the flagship journal of the public health profession. The American Public Health Association is the largest public health organization in the world. But look at the title. Building Trust for Engagement of Minorities in Human Subject Research. Is the glass half full, half empty, or the wrong size? You know, the optimist would say, well, it's half full. The pessimist, half empty. The engineer is the wrong size. And I submit to you there's something we can learn from the engineers. We've made progress, we have a lot of work to do, but maybe we're asking the wrong question. That's why I'm here with you. I challenge you to begin asking different questions. So I think there are tremendous opportunities that we have. One of those opportunities is reflected in this photograph. Now, I don't know about you, but as a public health professional for all of my professional career, we have lived for this moment. And I believe that 50 years from now, we'll be celebrating the signage of the Affordable Care Act. And 150 years from now, we'll be celebrating that this was the turning point in the history of our country to provide health care to all of our people. And I would like to think that this generation is excited about this. Am I right? Let me hear some enthusiasm in here. If you think the Affordable Care Act is a good idea, put your hands together. Work to do. We're making the transition from a sickness care system to a health promotion disease prevention system. Imagine right now that the only way that our current system works is that you have to be sick. And imagine that the sicknesses that people are coming into the hospital with are all preventable. That's what this change means. Our incentives right now are totally misaligned. and the realignment with the rest of the world. Every other industrialized nation in the world provides care to their people as a right. We're the only ones lagging behind until this happens. We are now heading into alignment. You know, the other exciting thing is to be in the great state of Maryland. Because on April 10th, 2012, the governor signed into law the Maryland Health Improvement and Disparities Reduction Act of 2012. It is the law in the state of Maryland to eliminate ethnic and racial health disparities. Give Marylanders a hand, will you? You've got to remove the policy barriers. You've got to make it easier to address these issues. And I was happy and excited to be there and to be part of the working group that produced the report that led and shaped the legislation. Now, the reason I share this with you because, as you can see, in 2012, we also, at the School of Public Health, did a major report called Transforming Health in Prince George's County. That is the county in which we live right here. And what's interesting about this report is that if you were to look at the economic distribution of counties, of African American communities in the nation, Prince George's County is the wealthiest black community in the nation. But we're not the healthiest. The state of Maryland is one of the wealthiest states in the nation. We have more people in the state of Maryland with a terminal degree, a PhD or a graduate degree, than any other state in the nation. But we're not the healthiest state. And so this report was designed to look at these health issues in Prince George's County. And as a result of this work and the legislation, guess what? There's going to be a brand new healthcare delivery system, $350 million plus already allocated to build a new healthcare system in this county. Now think about it. If you had a chance to build a new health system from the ground up, would you build your great-great-grandfather, did I get that far enough? Great-great-grandfather's healthcare system? Would you do that? This is call and response. You wouldn't do that, would you? But if we're not careful, that's exactly what will happen. You know why? Because they have a hammer, they build hospitals, and they will simply build a sickness care hospital because that's what they know how to do. We have a chance to shape what this healthcare system looks like in this county, and you guys need to be part of that. And I'm going to give you a roadmap so that you can be part of that. Say that's part of your contribution while you pursue your education here at the University of Maryland in College Park. Now, we have some serious challenges ahead of us. And here is where I'm going to simply say that a lot of my slides on the incidence and prevalence of disease I took out. You guys sit in classes all the time and see those things. What we're missing is, what is it about the social and historical context in which we're living that these diseases, again, totally preventable, are still occurring? What's driving them? What's fueling them? And I submit to you that we need a better understanding of the social context of health disparities. And as young, new physicians and other health professionals, this is what I'm asking you to put your attention to. I've used the images from the Civil Rights Movement, that's Dr. King, but it could be Cesar Chavez, it could be a whole range of people in this country who have experienced discrimination because of who they are and because of what they look like. They have all experienced the burdens of race and history. But the ultimate aim is to uncover the social, cultural, and environmental factors beyond the biomedical models. And this is what the key here is. And this is why the medical schools are opening themselves up to those from the humanities. It's not just STEM anymore. We have to get beyond the biomedical model and address a range of factors, including breaking the cycle of poverty, increasing access to quality health care, eliminating environmental hazards in homes and neighborhoods, and implementing effective programs tailored to community needs. So right now, it is not uncommon to take materials, American Cancer Society, American Heart, you name the group, that have been developed for the general population, and simply put it in Spanish. That's not cultural tailoring. It's not uncommon to take those materials and simply, instead of having white faces on it, put black faces on it. That's not cultural tailoring. You with me? So we're talking about, we got to go back to the neighborhoods, knocking on doors, meeting people, talking to them, and literally developing our interventions based on their cultural understanding. We also want you to recognize that because of the history of inequalities and racism in the healthcare system, many African Americans, Latinos, when I say that, think other minority groups, may delay seeking healthcare. That their beliefs about health and illness also influence a community's response to health communication messages that are designed to promote health and prevent disease. So you know, the messages are out there, but some people don't think that message is for them. Some people don't believe the message. Some people don't trust the message. And we believe this is directly related to the history of their experience in this country, a history that gets passed on in word of mouth in many communities. And so when I talk to you about health disparities, we're not talking about a difference in an incidence and a prevalence of disease or life expectancy. This is from Healthy People 2020. This is the nation's roadmap for improving the health of the American people. A health disparity is a particular type of health difference that is closely linked to social, economic, or environmental disadvantage. You with me? It is caused by something outside the individual. It's caused by the social, economic, and environment in which they live, and the experience of being discriminated against simply because of what they look like. Now, it's very interesting that in today's front page New York Times, you know what we're celebrating? We're celebrating LBJ. Fast. They do know that. LBJ signed the Civil Rights Act. And see, since I'm dating myself now, I was born, go back to, the time we walked uphill to school, going both ways, in 1953. When I was young, we would travel to my grandmother's home in Texas. I have any Texans here? Go back down south. And there would be signs on the water fountain, black and white. You guys probably see this in historical movies, but I remember this as a child. When LBJ signed that law, those signs were taken down all over the nation. And over time, we've gotten rid of these blatant examples of racial discrimination. Nobody could ever have imagined that the vestiges of that discrimination still exist today. And no one could have ever imagined that it exists in our healthcare delivery system. The Institute of Medicine's report, Unequal Treatment, Addressing Racial and Ethnic Disparities in Healthcare, demonstrated that even when minorities have the same ability to pay, in other words, they have insurance, even when minorities have the same diseases, they get treated differently when they come into the hospital. Now, when they interviewed the doctors and showed them the data, here's what the doctors said. We don't see race. We treat everybody the same. Right? We just look at the facts and we treat based on the science. But the reality is, the data told a different story. And as a result of the Institute of Medicine's report, guidelines were put in place to require cultural competence training of healthcare professionals. We submit that that's important, but not sufficient to address the problem. In other words, we all have unconscious bias. We take that with us into our professions, including medicine. Note here, in contrast, health equity is the attainment of the highest level of health for all people. In this country, we make the comparison of health between the minority groups or the disadvantaged groups with the majority or the advantaged groups. That translates many times into people of color versus whites. What you need to know is that white people in America, in a country where we spend more money than any country in the world on medicine and healthcare, the most well-off in this country are not the healthiest in the world. We have to go to Sweden, Scandinavia, Japan, where we have the healthiest people in the world. So if we really want to talk about closing the gap, we would look at other nations. So our bar, while significant, is not the highest level of health. But that's what health equity means. Now this comes from the front page of the New York Times in December. It was a striking image tackling the racial gap in breast cancer survival. And it included a video component. And here's what was most disturbing about it. Talking about 2013. If you're black, breast cancer first diagnosis at stage 3 or 4. Okay? Now, let me put it like this. You think of a baseball or an orange, okay? Black women are showing up to the hospital with a mass that size, and they're being seen for the very first time. When your disease is that advanced, all of these breakthroughs that we've made in breast cancer treatment don't work anymore. So in this country, more white women develop breast cancer, but more black women die from breast cancer. Some of that is related to late-stage diagnosis. And I submit to you, some of that late-stage diagnosis is related to disparities associated with being discriminated against in our society. Do they not get the message about, every time I turn around, I see pink ribbons. I see my favorite football players running in pink shoes. I got the White House turning their fountain pink. The message is out there, but everybody's not seeing that message. That's right. Now, because of the Affordable Care Act, what they call essential services, which are the screenings, preventive screenings, are of no cost, no copay. No copay for prostate cancer screening, no copay for breast cancer screening, no copay for colorectal cancer screening. Do you follow me, people? It's a life-saving developments. But if we're not careful, everyone will not get that message. So we believe there is a framework for moving forward. And that framework includes thinking about disparities in this way. First-generation disparities research focuses on documenting the disparity. You sat in classes where you just see tons and tons of statistics, infant mortality, you name it. That's simply the documentation of the problem. You know what? We've been documenting the problem ever since we've collected statistics. You know, the history of racism and discrimination in medicine and public health would be easy to ignore it were it not so well documented. That's first-generation disparities research. Second-generation disparities research explains the reasons for the disparities. Oh, these women are dying before their time because they don't have a high school education, because they live in poverty. You know, we come up with the reasons why. Because they live in a part of the country that doesn't have access to comprehensive cancer care. You can do first and second generation disparities research and never leave your computer screen, just looking at data being collected. Third generation disparities research provides promising solutions for the elimination of disparities. These are the randomized clinical trials. These are typically short-lived, but this is the gold standard of the scientific evidence base for what works. This is why that title is so important. The evidence base for what works right now is colorblind. Because racial and ethnic minorities are not represented in the clinical trials. And as a result, some of the evidence, we're not sure it works for them. So in 2011, we published this article called "For a Fourth Generation of Disparities Research to Achieve Health Equity." And in this, we proposed what we call the Health Equity Action Research Project, a platform for fourth generation disparities research. I want you all to be fourth generation physicians, right? Fourth generation health professionals. And it takes race front and center. It looks at the structural social determinants, and it uses all the prior generation research to take action. It literally go out to where people live, work, play, and worship, and deliver to them in a culturally tailored strategy what they need to save their lives. And as I want you to finish on, and I hope we can have a robust conversation, I'm going to tell you what some of this looks like in the field and where I need your help. We call this the Care Project. Health advocates in reach and research. Now, how many of you have ever been in a black barbershop or beauty salon? Raise your hand. All right, people of color. Look next to your neighbors who didn't raise their hand and tell them, no self-respecting black barber would ever say, I'll get you in and out in 15 minutes. It's an all-day affair, and you're there all day, and it's a hoot, it's a party, it's a conversation, and I've seen firsthand a barber have more power than a doctor. And it was when I was sitting in the barbershop myself, and the gentleman came in, and you've got the music playing, you got the TV on, and they said, hey, Joe, where you been? He said, I've been in the hospital. I fell out. They said I had high blood pressure. They kept me in the hospital for 3 days. And they said I have hypertension, and I've got to keep it under control by taking these pills for the rest of my life. Now, you got multiple conversations going, you got the TV on, you got the music playing, and yet there's a certain intimacy in that moment. And everybody's listening. And the barber says, Joe, if you take those pills, you won't be able to keep up your obligations. This is a young crowd here. Can you help them with obligations? Come on. Do you know what obligations are? You're not quite sure, are you? SEX. If you take those pills, you won't be able to, you with me? Follow me now? I looked at Joe's face. Joe just got out of the hospital. Joe got diagnosed. Joe got a prescription. Joe's not taking those pills. I saw a barber have more power than a doctor. And we said, what if we actually enlisted that barber as a partner? And he reinforced the evidence-based message. And that is the origin of the Hair Project. It's received awards. As you can see in this image here, this is one of our grad students. We bring physicians and nurses and pharmacists into these shops. We have a whole team from the Career Smith Center for the Performing Arts, the Digital Cultures Group. They're doing art and work to describe this setting. We want to transform barbershops and beauty salons into health information portals. And what's so interesting about it, because of the technology, I can go into these shops now and literally do telemedicine. I can go into these shops and Skype with a physician at the Mayo Clinic or wherever that physician might be anywhere in the world. We can show ways in which the miniaturization of new diagnostic tools free us from the clinic, free us from the hospital, and enable us to meet people where they live, settings that they trust. So we're looking for volunteers to join us in our campaign, in our hair campaign. In September, I mentioned this to Wendy, we will host on this campus, you don't have to go anywhere, you just have to come to campus, in the Cole Field House, what we call the Health Equity Festival presents a Mission of Mercy. Raise your hand if you've ever heard of a Mission of Mercy. I've got 3 hands from this big audience. Did you volunteer? But you heard of it. You know it has to do with the dentist, right? You know it has to do with dentists? You know that?
It's a little not thinking about
Okay. Many of these kinds of programs go around the world to remote places. Those activities are now happening here in our own country. In September 5th and 6th, there will be 100 dental chairs set up in the Cole Field House. There will be volunteer dentists and health professionals and a complete health festival, wraparound health festival. And we will be able to serve 1,000 people at no cost to them. Last year, $560,000 worth of free care was delivered. Extractions, fillings, crowns, no cost. The Maryland Dental Society, the Department of Health and Mental Hygiene, Maryland Center for Health Equity, and Catholic Charities is making this possible. Can you imagine Raise your hand if you've ever been in Cold Field House. That empty space, underutilized, that big green. Truck will pull in on Thursday, and an amazing transformation will take place as 90 chairs are set up, complete with all the vacuum, sanitation, everything it takes to do clinical care. And the following day, people will come in. And as they come in and they move through that vast space, they will be escorted from one station to the next. And that's where we need escorts. Because you know what? Somebody who shows up to a mission of mercy has more than two things. It's the same person that's at risk for type 2 diabetes. It's the same person at risk for cardiovascular disease. That's the same person at risk for maybe not having enough to eat. So we're not just going to deal with their teeth. We're going to deal with their whole person. And I want you don't even have to leave this campus. You have a chance to see firsthand what's possible when you have what? Fearless ideas. Isn't that what we have on our buses? Fearless ideas. Fearless ideas inspire social change. That's not just a slogan. It's real. But you need an on-ramp to experience it. You need an on-ramp to demonstrate it. You need a context to make it real for you. And Wendy, I want it to be real for these guys. And to be able to do that on our own campus. Now, many of these dentists were sitting in chairs just like you years ago, when they actually used to play basketball in that arena and won many of their awards. And their memories, just like your memories of college, are of that field house. Now they're graduated, went on to get degrees in dentistry and medicine and nursing. And for them, it's such an honor and pride to come back and turn that space, because to them it's like sacred space, into a place to serve the most loved. And I want you to be part of that. Let me stop there. We have a number of things on our website, a lot of resources. I don't want to put you guys to sleep, but I do want to fire you up and know that the School of Public Health Center for Health Equity has an on-ramp for you, and a way for you to engage real people, not just statistics, but to put a face on those statistics in ways that hopefully inspire you to be great as you pursue your careers in health sciences. And with that, thank you very much. It's time for... Sure.
You gonna talk to them about the drum circle?
Can you pull that up on the screen while I talk to them?
I think.
Just go to the website where you had it. And so, how many will be at Maryland Day? Woo, woo, woo. I know you all want to see the cow with the hole in its belly and the little ponies and things. But our idea, we have a fearless idea. And it's called the Health Equity Drum Circle. And if you get to our page, just go right up, hit the main page right there. Just click there. Click right here where it says, click here for more. There you go. And what we said was this. First form of communication was a drum. And just go ahead and maximize it over in that top corner. There you go. How about setting a new, you ready for this? Guinness World Record for the largest hand drum ensemble in the world. So we will go for our attempt on Maryland Day. And we are so pleased that we have a corporate sponsor, for those of you who don't have drums. Who has a drum? What drum do you have? Very good. Are you part of the drum circle? Well, we're going to get you back in. We have a corporate sponsor that has donated 750 tambourines with a head. So a lot. There will be 100,000 people roaming the campus on Maryland Day. And we've got to get some of them into Byrd Stadium, where there will be a huge festival and like a concert with some of the drum masters from around the region. And at 2 o'clock, we will start banding people according to the Guinness record requirements to go for the record. The current record was set in India, 1,300 people. Our effort, 1,400 people. So we need those, some of those folks roaming Maryland Day, we can actually pull this off. And for the 750 who show up, well, I didn't know about it, I just heard about it today, I don't have a drum line, everyone. 750, so over half, we can literally give people drums. It's going to be, at 2 o'clock, you're going to hear a cannon, if everything works. You're going to hear a cannon go off, boom, just like they do when they get a football touchdown. Now we'll start the countdown. President Wallace Lowe is scheduled to arrive at 3 o'clock. He'll come into the stadium like a rock star. We'll give him a conga, tambourine, whatever he can, and we're going to go for the record. According to Guinness, you have to sustain a rhythm for 2 minutes. It says it's not how long you play, it's how many people play. So we are going to go 2.5 just to make sure. It has to be verified through videography and photography. It's really going to be awesome. We just produced a video with the Career Smith Center that's going to teach you the initial beat, practice before you get there, and we'll do more at the time of the event. So we have cards, and I'll give you postcards, and the School of Public Health's tip on the main mall will also have information. So you can roam around, eat the hot dogs, see the cow with cold belly, and the ponies, and then at 2 o'clock head over and bring people with you. First day will have people. Who has a Facebook account here? Who has a Twitter account? Who knows what trending means? We are going to trend on Twitter for Maryland Day. So we'll be, I'll send an email link for the flyer. Wendy, can I have you click to scroll down a little bit? And I would just ask for you Facebook people, like us on Facebook. And for you Twitter people, I need more than just my 5 family members following me. Follow me on Twitter. And click on the registration.
Here for more?
Yeah. Okay, go back. That may be Maryland thing. I think it's, yeah. But at the very, very top, you can just still there. There.
This one.
Right.
Okay.
Go down where it said register. Oh, there it is. Go back to the Facebook, please.